A very warm welcome to the viewers of this channel. I am Dr. Sparsh Singh, Junior Resident in Department of Orthopedics at ERALMCH Lucknow Medical College and Hospital. Today we are going to discuss seronegative spondyloarthropathies. Introduction. The seronegative spondyloarthropathies are a group of overlapping disorders that share certain clinical features and genetic associations. Most common of them all is ankylosing spondylitis. Other diseases include psoriatic arthritis, reactive arthritis, juvenile spondyloarthropathy, undifferentiated spondyloarthropathy, and inflammatory bowel diseases associated arthritis. This is a picture showing chromosome number 6, which has a short and a long arm. The short arm has class 1, class 2 and class 3 MHC proteins, out of which the HLA-B27 is located on the class 1 MHC. And HLA-DR, which is also responsible for causing rheumatoid arthritis, is located on the class 2 MHC. Let us look at the common features. They all are seronegative, that is, rheumatoid factor is absent, rheumatoid nodules are absent, there is a frequent association of HLA-B27, a tendency to occur in the same family, that is familial aggregation, inflammatory axial arthritis, generally sacroiliitis and spondylitis, oligoarthritis, generally with asymmetrical presentation, enthesis, that is inflammation of the tendons and ligaments, example plantar fasciitis, Achilles tendonitis, costochondritis. Extraarticular features such as involvement of the eye, anterior uveitis, skin, genitourinary tract. Now let us look at ankylosing spondylitis in detail. Ankylosing spondylitis is an inflammatory disorder of unknown cause that primarily affects the axial skeletal, peripheral joints and extraarticular structures. It is also called Mary-Strumpel's disease when it is associated with HLA-B27 and Bech-Drew's disease when it is not associated with HLA-B27. Epidemiology. Males are affected more frequently than the females. Estimates vary from 2:1 to 10:1. Onset is between 15 and 25 years. There is a strong tendency to familial aggregation and association with genetic marker HLA-B27. Pathology. Sacroiliitis is the earliest manifestation of ankylosing spondylitis. Synovitis, pannus, myxoid marrow, subchondral granulation tissue and marrow edema are found. In spine, there is inflammatory granulation tissue at the junction of annulus fibrosus and vertebral bone. The outer annular fibers are eroded and replaced by a bone, forming syndesmophytes. Pathogenesis. The pathogenesis of ankylosing spondylitis is thought to be immune mediated, but there is no direct evidence for autoimmunity. There is uncertainty regarding the primary site of the disease initiation. The pathogenesis of ankylosing spondylitis can be explained by these hypotheses. First is arthritogenic peptide hypothesis, where the HLA antigen is identified by CD8 receptors and T cells. Then misfolding hypothesis, where the endoplasmic reticulum dysfunctions and causes misfolding of HLA gene, and there is an unfolded protein response which leads to autophagy of the cell. Then activation of innate immune system by aberrant HLA-B27. This leads to activation of monocytes, NK cells and T cells, and also by humoral immunity, leading to activation of inflammatory mediators. Clinical manifestations. The symptoms of the disease are usually first noticed in late adolescent or early childhood. The initial presentation of ankylosing spondylitis generally occurs in SI joints. Involvement of the SI joint is required to establish the diagnosis. SI joint involvement is followed by involvement of the discovertebral, apophyseal, costovertebral and costotransverse joints. The initial symptom is usually a dull aching pain which is insidious in onset, felt deep in the lower lumbar gluteal region, accompanied by low back morning stiffness of up to a few hours duration, which improves with activity and returns following an inactivity. Arthritis in the hips and shoulder occur in 25 to 35% of the patients. Arthritis of the peripheral joints other than the hips and shoulder usually are asymmetric, occurs in another 30% of the patients. A patient of ankylosing spondylitis has a stooped over position in advanced cases. Neck pain and stiffness from involvement of cervical spine are a late manifestation. Chest expansion is measured as the difference between maximal inspiration and maximal forced expiration in the fourth intercostal space. Normal chest expansion is 5 cm and anything below 5 cm is considered abnormal. Now let us look at Schober's test. The original Schober's test was performed by drawing a point between the dimple of Venus's and another point 10 cm proximal to this. And the patient was asked to bend forwards. A difference of more than 5 cm was considered normal. But now we use a modified Schober test. In this test, marks are made 5 cm below and 10 cm above the sacral dimples. The distance between these marks should be increased from 15 cm to at least 20 cm with lumbar flexion. The distance less than 5 cm is considered as abnormal. Peripheral musculoskeletal involvement occurs in 30 to 50% of the patients. The following are common peripheral musculoskeletal structures like Achilles tendonitis, plantar fasciitis, tibial tuberosity, superior and inferior poles of the patella, and iliac crest. Extra-articular manifestations include uveitis, cardiovascular disease, pulmonary disease, renal disease, neurologic disease, and GI diseases. Uveitis is also called iritis or iridocyclitis. It is the most common extra-articular manifestation of ankylosing spondylitis, occurring in about 20 to 30% of the patients. It is usually acute, unilateral, and non-granulomatous. Cardiovascular involvement, aortitis of the ascending aorta resulting in aortic valve insufficiency, mitral valve insufficiency, and atrioventricular block. Pulmonary involvement include restrictive lung diseases, bilateral apical pulmonary fibrosis. Renal involvement include amyloidosis, which is a very rare complication of ankylosing spondylitis in patients with severe, active, and long-standing disease. GI involvement include asymptomatic inflammation of the proximal colon and terminal ileum has been observed. Let us look at the laboratory findings. No laboratory findings is diagnostic of ankylosing spondylitis. 90% of the patients are associated with HLA-B27. Erythrocyte sedimentation rate and C-reactive proteins are elevated. There is mild anemia due to chronic disease. Patient with severe disease may also show elevated alkaline phosphatase, elevated serum IgA levels, and they are negative for rheumatoid factor, anticyclic, citrullinated peptide, and antinuclear antibodies. Radiographic findings include the earliest sign can be detected by 3 to 6 months after the onset. Sacroiliac joints are the most common joints. Early patchy osteoporosis develop around the distal third of both the bones. Joint margins become ill-defined and the joint intervals become widened. Subchondral erosion starts when they are multiple, they produce a rosary effect. New York criteria gave grades for sacroiliitis. According to this, there are 5 grades from 0 to 4. Grade 0 is considered as a normal SI joint. Grade 1, suspicious changes at the left, in this case at the left sacroiliac joint in the form of slightly irregular joint facets. Grade 2, minimal abnormalities in the form of small erosions, the black arrow, and slightly condensed bone sclerosis, the white arrow. Grade 3, manifest abnormalities in the form of erosion and sclerosis in addition to widening of middle part of both the sacroiliac joints. And grade 4 is total ankylosis of both the sacroiliac joints. In lumbar spine, the earliest change is squaring of the anterior portion of the vertebral bodies. The anterior concavity of the body is lost. This is found initially at the upper lumbar and lower thoracic regions and there is a loss of lumbar lordosis. A shiny corner sign or a Romanes sign can be seen on the X-ray. Paravertebral ossifications develop beneath the anterior longitudinal ligaments within the annulus at each level. The ossification develops vertically in contrast to those developed in osteoarthritis. Finally, the spine takes appearance of a bamboo spine. In cervical spine, extreme bony bridging extends along the anterior aspect of the vertebral bodies. There will be loss of lordosis and apophyseal joints become ankylosed. In the hips, severe osteoporosis can occur in both sides of the joints. Erosion develop and the joint space become reduced and in advanced cases ankylosed. To qualify as criterion for inflammatory back pain of axial spondyloarthropathy, there should be a chronic back pain of about 3 months and they should have 4 or more of these characteristic features. Number 1, age of onset below 40 years. Number 2, insidious onset. Number 3, improvement with exercise. Number 4, no improvement with rest. And number 5, pain at night with improvement upon getting up. The Rome criteria, which is also the oldest criteria for diagnosing ankylosing spondylitis. According to this, as is diagnosed if bilateral sacroiliitis is seen along with one of the following: low back pain and stiffness of 3 months duration not relieved by rest, pain and stiffness in thoracic spine, limited lumbar spine movement, limited chest expansion, history or evidence of iritis or its sequelae. Modified New York criteria for ankylosing spondylitis. Ankylosing spondylitis is diagnosed if radiological criteria plus at least one clinical criterion is met. Clinical criteria include low back pain and stiffness persisting for more than 3 months, improved by exercise but not by rest, limitation of movement in lumbar spine in both frontal and sagittal planes, limitation of chest expansion relative to normal values for age and sex. Radiological criterion include grade 2 or more than 2 sacroiliitis bilaterally on plain radiography or grade 3 or 4 sacroiliitis unilaterally on plain radiography. Another grading system which is given more recently, ASAS classification criterion for axial spondyloarthropathies. In patient with back pain more than 3 months and age of onset less than 45 years, sacroiliitis on imaging plus one or more than one spondyloarthritis feature such as inflammatory back pain, arthritis, enthesitis at the heel, uveitis, dactylitis, psoriasis, Crohn's disease or ulcerative colitis, and they have good response to NSAIDs, family history, HLA-B27 and elevated CRP levels. Or HLA-B27 plus more than 2 of the other spondyloarthropathy features. Sacroiliitis on imaging should have active inflammation on MRI, highly suggestive of sacroiliitis associated with spondyloarthropathy, or definitive radiographic sacroiliitis according to modified New York criteria. Now let us move on to treatment. The general measures include the patients are encouraged to remain active and follow their normal pursuits as far as possible. They should be taught to maintain satisfactory posture and to perform spinal extension exercises every day. Swimming, dancing and gymnastics are ideal form of recreation. Rest and immobilization are contraindicated because they tend to increase the general feeling of stiffness. This is a slide showing exercises for low back pain and associated with ankylosing spondylitis, standing hamstring stretch, leg raise and arm raise, side planks, gluteal stretch, cat and camel, pelvic tilt, partial curls and extension exercises of the spine. Non-steroidal anti-inflammatory drugs. NSAIDs improve spinal pain, peripheral joint pain and function over a short period of time, 6 weeks. They do not prevent or retard the progress of ankylosis. TNF inhibitors like etanercept, infliximab, adalimumab, golimumab and certolizumab have all been approved by US Food and Drug Administration as therapies for ankylosing spondylitis and are indicated after NSAIDs therapy has failed. Infliximab, an adult dose of about 5 mg per kg IV at 0, 2 and 6 weeks, then every 6 weeks. Etanercept, adult dose of 50 mg subcutaneously once weekly or 25 mg subcutaneously twice weekly. If twice weekly, doses should be given on the same day or 3 to 4 days apart. Adalimumab, 40 mg subcutaneously every second week. These therapies are generally reserved for individuals who have failed to be controlled with non-steroidal anti-inflammatory drugs. Now let us look at surgical procedures for lumbar spine. Described by Smith and Petersen, Larson and Offrank in 1945, if the flexion deformity is severe, the patient's field of vision is limited to a small area near the feet. Respiration becomes almost completely diaphragmatic. Gastrointestinal symptoms like dysphagia or choking may occur. In addition to improvement in function, the improvement in appearance made by correcting the deformity is achieved. SMITH-PETERSEN osteotomy. This is an excellent option for correction of small degrees of spinal deformity. Bone is removed through the pars and facets of the joint. Symmetrical resection is necessary to prevent creating a coronary deformity. Approximately 10 degrees of correction can be obtained with each 10 mm of resection. The osteotomy is closed with compression or with in situ rod contouring, and bone graft is applied. This is a figure showing osteotomy of the joint and then later achieving lordosis at the spine. Another osteotomy is pedicle subtraction osteotomy, which is also called as the 3-column osteotomy, best suited for patients who have significant sagittal imbalance of 4 cm or more and immobile or fused disc. An entirely safer procedure than Smith-Petersen osteotomy because it avoids the need of multiple osteotomies. Typically 30 degrees or more of correction can be obtained with a single posterior osteotomy at the level of the deformity. This is an example of subtraction osteotomy. Another osteotomy is eggshell osteotomy, reserved for severe sagittal or coronal imbalance of more than 10 cm from the midline. This requires both anterior and posterior approaches. After posterior elements have been removed and pedicles have been collapsed outwards, long sharp curette is used to collapse the eggshell. ACR 2019 and Spondylitis Association of America and Spondyloarthritis Research and Treatment Network have given certain guidelines for the treatment of the disease. For active disease, first line drugs like NSAIDs and physiotherapy is given. If peripheral arthritis persists, add local glucocorticoids. If 2 or less joints are involved, add sulfasalazine. If there is isolated sacroiliitis or enthesitis, NSAIDs and injection glucocorticoids in the SI joint can be given. Second line drugs are given if there is no relief from NSAIDs. TNF inhibitors like etanercept, infliximab and certolizumab are added. If there is ankylosing spondylitis with uveitis or ankylosing spondylitis with inflammatory bowel disease, we prefer monoclonal antibodies like secukinumab, EGGSHELL, adalimumab and golimumab. Third line drugs are used if there is active ankylosing spondylitis even after using TNF inhibitors. There are two types of patients in this. Primary non-responders are those patients where there is no relief at all after 6 months of the therapy. We change the drugs to secondary monoclonal antibodies or small molecules like tofacitinib. Secondary non-responders are patients who initially responded to the therapy but later on they could not respond. In these patients, we try a different TNF inhibitor. For stable ankylosing spondylitis, NSAIDs on demand are given and physiotherapy is given. If the patient is stable on biological demands like sulfasalazine, increase the interval of dosing. If the patient is stable on TNF inhibitor, then NSAIDs are stopped. If the patient is stable on TNF inhibitor and a small molecule like tofacitinib, then tofacitinib is stopped. If the patient is stable on TNF inhibitor alone, then it is continued. Joint replacement for joints like hip can be done, and the patients with the total hip replacement are benefited from this. Heterotropic bone formation may occur after total joint replacement, especially around the hip. This heterotropic formation can be reduced by giving NSAIDs like indomethacin or employing radiation therapy post-operatively. Now let us move on to reactive arthritis or Retter's syndrome. Reactive arthritis refers to acute non-purulent arthritis complicated by an infection elsewhere in the body. This syndrome was described by Hans Ritter in 1916, hence it is called Retter's syndrome. A clinical triad of urethritis, arthritis and conjunctivitis occur some weeks after dysentery or genitourinary tract infection. The etiology include gut pathogens like Shigella flexneri, Salmonella, Campylobacter species and Yersinia enterocolitica. Lymphogranuloma venerum and Chlamydia trachomatis have been implicated in sexually transmitted infections. Pathology. The pathological changes are essentially the same as those in ankylosing spondylitis, with emphasis on large joint synovitis and chronic disease course tending towards sacroiliitis and spondylitis. Clinical features include the most common age group is 18 to 40 years, can occur in children over 5 years of age and in adults. Men are more commonly affected. The ratio is about 10:1. In acute phase of the disease, it is marked by an asymmetrical inflammatory arthritis of lower limb. Knee, ankle, subtalar, metatarsophalangeal and toe interphalangeal joints are most commonly involved, but the wrist and fingers can also be involved. Dactylitis or sausage digit, a diffuse swelling of solitary finger or toe, is a distinctive feature of reactive arthritis. This is a figure showing dactylitis or a sausage finger. Tendo Achilles or plantar fasciitis are common. In males, urethritis, and in females, cervicitis or salpingitis are common. Ocular disease such as asymptomatic conjunctivitis to an aggressive anterior uveitis. The characteristic skin lesions are keratoderma blennorrhagica. This is an example of keratoderma. The chronic phase is more characteristic of spondyloarthropathy with features resembling those of ankylosing spondylitis. Laboratory findings include tests for HLA-B27 are positive in 75% of the patients with sacroiliitis. ESR may be high in active phase of the disease. Radiographic findings include in early or mild disease, radiographic changes may be confined to juxta-articular osteoporosis. With long-standing persistent disease, marginal erosions and loss of joint space can be seen in affected joints. Sacroiliitis and spondylitis may be seen as a late sequelae. Sacroiliitis is more commonly asymmetric than in ankylosing spondylitis and can begin anywhere along the lumbar spine. The syndesmophytes may be asymmetric, coarse and non-marginal. Treatment. The most patients with Retter's disease benefit to some degree from high dose of NSAIDs. Indomethacin 75 to 150 mg in divided doses is the initial treatment of choice, but other NSAIDs may be tried. Majority of patients with chronic reactive arthritis due to chlamydia benefited significantly from a 6-month course of rifampicin 300 mg daily plus azithromycin 500 mg for 5 days and then twice weekly, or 6 months of rifampicin 300 mg daily plus doxycycline 100 mg twice daily. Tendinitis and other enthesitic lesions may benefit from intralesional glucocorticoids. Topical steroids may be used for uveitis, and TNF inhibitors like infliximab may be used in refractory cases. Now let us look at psoriatic arthritis. Psoriatic arthritis refers to arthritis that occurs in individuals with psoriasis. 60% of these patients will have a positive association with HLA-B27. Pathology. The inflamed synovium in psoriatic arthritis resembles that of rheumatoid arthritis, although with somewhat less hyperplasia and cellularity than rheumatoid arthritis and greater vascularity. Unlike rheumatoid arthritis, psoriatic arthritis shows prominent enthesitis with histology similar to that of other spondyloarthropathies. Clinical features: in 60 to 70% of the cases, psoriasis precedes joint disease. In 15 to 20% of the cases, the two manifestations appear within 1 year of each other. In about 15 to 20% of cases, arthritis precedes the psoriasis. This is a table showing features that distinguish psoriatic arthritis from rheumatoid arthritis and osteoarthritis. Here we can see that distal interphalangeal joint is more commonly involved in psoriatic arthritis. Enthesitis is more common in psoriatic arthritis. Dactylitis and erosion and new bone formation is more common in psoriatic arthritis, along with skin involvement. The spectrum of arthropathy associated with psoriasis is broad. 5 patterns are described. Number 1, arthritis of the DIP joints. Number 2, symmetric oligoarthritis. Number 3, symmetric polyarthritis similar to rheumatoid arthritis. Number 4, axial involvement like spine and sacroiliac joints. Number 5, arthritis mutilans, a highly destructive form of the disease. Nail changes, pitting of the finger and toes occur in psoriatic arthritis. Widespread shortening of the disease or digits, or also known as telescoping, is seen. Eye involvement, either conjunctivitis or uveitis, is reported in 7 to 33% of psoriatic cases. Laboratory findings include raised ESR and CRP levels. In about 10% of the patients have anti-CCP antibodies. Uric acid may be elevated in presence of extensive psoriasis, and HLA-B27 is found in 50 to 70% of the cases with axial disease, but 20% in patients with only peripheral joint involvement. Radiographic findings include characteristics of peripheral psoriatic arthritis include DIP joint involvement, including a classic pencil in cup deformity. Marginal proliferative erosions, small joint ankylosis, osteolysis of phalangeal and metacarpal bone with telescoping of the digits, periostitis and proliferative new bone at the site of enthesitis is seen. In the spine, asymmetric sacroiliitis is seen compared with idiopathic ankylosing spondylitis. There is less apophyseal joint arthritis, fewer and less symmetric and coarse syndesmophytes. Let us look at the classification criteria for psoriatic arthritis. Number 1, evidence of current psoriasis, a personal history of psoriasis or a family history of psoriasis. Evidence of current psoriasis on examination is given 2 points, 1 for personal history and 1 for familial history. Typical psoriatic nail dystrophy, 1 point. Negative test for rheumatoid factor, 1 point. Dactylitis on examination, 1 point. Personal history, 1 point. And radiographic evidence of juxta-articular new bone formation, 1 point. With 3 or more than total points from any of the 5 categories will meet the criteria. Treatment: in mild disease, no more than topical preparations to control skin disease and NSAIDs for the arthritis are needed. In resistant forms of arthritis, immunosuppressive agents like methotrexate and TNF inhibitors like infliximab, etanercept, adalimumab are effective. Etanercept 50 mg subcutaneous once weekly or 25 mg subcutaneous twice weekly. If twice weekly, doses should be given on the same day or 3 to 4 days apart. Adalimumab 40 mg subcutaneously 1 week apart. Infliximab 5 mg per kg IV at 0, 2 and 6 weeks and then every 8 weeks. Let us move on to enteropathic arthritis. Both forms of inflammatory bowel disease, ulcerative colitis and Crohn's disease are associated with spondyloarthropathy. 2 types of involvement are seen: peripheral and sacroiliitis and spondylitis. Number 1, Peripheral arthritis. Peripheral arthritis occurs in about 15% of the patients with inflammatory bowel disease. Typically, large joints are involved in asymmetric fashion. Synovitis and joint erosion can occur. Men and women are affected with equal frequency, and no particular association with HLA-B27 is seen. Number 2, sacroiliitis and spondylitis. This pattern is seen in about 10% of the patients with inflammatory bowel disease. HLA-B27 is positive in 60%, and there is an increased incidence of ankylosing spondylitis in close relatives. Unlike the peripheral arthritis, sacroiliitis show no temporal relationship to gastrointestinal inflammation, and its course is unaffected by treatment of bowel disease. Laboratory findings include 30 to 70% carry HLA-B27 gene. Radiographic findings, radiographic changes in axial skeletals are the same as in uncomplicated ankylosing spondylitis. Treatment: infliximab and adalimumab are effective for induction and maintenance of clinical remission in Crohn's disease and ulcerative colitis. Treatment for inflammatory bowel disease includes sulfasalazine and related drugs. Systemic glucocorticoids and immunosuppressive drugs are also usually of benefit for associated peripheral arthritis. Then undifferentiated and juvenile onset spondyloarthropathies. Patients who do not meet the classification of criteria are included in this. Approximately one half of the patients with undifferentiated spondyloarthropathy are HLA-B27 positive. In familial cases, which are much more frequently B27 positive, there is often eventual progression to classical ankylosing spondylitis. Juvenile onset spondyloarthropathy begins between age of 7 and 16 and most commonly in boys 60 to 80%. And asymmetric, predominantly lower extremity oligoarthritis and enthesitis occurs. Extraarticular features are absent. There is a prevalence of HLA-B27 in this condition, which is approximately 80%. Many of these patients go on to develop ankylosing spondylitis in late adolescent or adulthood. Management of undifferentiated spondyloarthropathies is similar to that of other spondyloarthropathies. Thank you and have a great day.